So what are some of the common behavioral challenges that caregivers face, that we face, as we try to care for people in the later stages of dementia? And what I would say to you is we need to quit seeing this as behavioral challenges and start viewing this as meeting unmet needs. People with dementia have unmet needs, and they have challenges in how they communicate those. They're doing the best they can. They're trying to let us know something's not working for them, something's not right. They want or need something that they don't have. Our problem is recognizing that and figuring out what is it and how can we help. So I could show you a whole laundry list of possibles. Everything from not having a healthcare power of attorney, and so we're having to make choices when there is no one to advise us, all the way through not wanting to go to the doctor, refusing care, not doing what should be done, swearing, cursing, sex talks, mixing up day and night, not sleeping, sleeping all the time, not starting, not being able to stop, perseverating. We can go all through seeing things, hallucinating, wandering, eloping, threatening caregivers, being rude, feeling sick, striking out, falls, injuries, contractures, infections and pneumonias, and problems with eating and drinking. The reality is those are all symptoms that happen as the person's dementia progresses. For many, many people, not everyone, but frequently. What we want to start doing is start helping families appreciate, you know what? In this case, we're getting to a place where we're getting later in the disease, the person's cortex is dying, and when that happens, muscles get turned on and now there's no off switch. So what we're seeing is simply progression. They're curling into a fetal position, not because of poor care or lack of ability of a caregiver to try to help with range of motion, but because the brain is dying. And when the muscles get turned on, the strongest muscles tend to win, flexion and abduction. So my posturing, you're not going to win. And to try to fight that actually causes a lot of discomfort. Toward the later stages, I may not be hungry or thirsty because the center core of my brain, my thrive to survive, is not signaling hunger and thirst. And in fact, I may be having trouble with chewing and swallowing and breathing, because when these muscles tighten up, it also tightens up my rib cage. And when I go to swallow something you put in there, I don't have much time to get it past the airway, and you may hear, well, that's not necessarily a signal that I need more fluid or that I've got a dry mouth. That could very well be aspiration. I'm trying to cough, but I don't have a clear cough. And yet in other cases, I may not even know that I need to do that because my brain is so badly damaged. Our challenge is help families learn the art of letting go in these areas and yet not give up and give good care. So what do we need to do? Well, there's some basics. We want to be good detectives, not judges. We don't want to immediately jump to judgment. We want to look, we want to listen, we want to offer some ideas, we want to think through things, make good choices that are based on not only what the caregiver is thinking, but also what the person with dementia might be trying to share, what they're showing us, what they're telling us with their bodies if they don't have words. We also want to think about using our approach, how we engage people, how we interact with people, as an assessment tool, a screening device. It's called dynamic assessment, because I want to assess you in the moment. What kind of data are you taking in, and what are you doing with it, and how are you using it? And so the cues that we want to use are visual cues, things that people can see, auditory cues, both sounds, texture, tones, rhythm, but also words to see what comes through, and then touch. How do we use touch? Movement. What happens when we try things? And then finally, we're going to want to match what we're asking with what they can do and support. So to do that, we want to keep in mind there are always 6 pieces to a puzzle. It's not all about them. It's about what we do. Yes, it's who've they been, what do they like, what's their life story. But it's also what level and type of dementia or dementias might they have on board. Then it's what other medical conditions, what sensory changes are happening to eyesight and hearing and touch, neuropathies. And then what medications and what psychiatric illnesses they might have on top of everything else, including depression. We want to also look at the environment. Are there things around them sights, sounds, textures, temperatures, smells that make a difference. Additionally, we want to look at the care partner and how they're doing, how they're touching, how they're sounding, how they're looking. Is it fast? Is it slow? Is it matching? Is it familiar or unfamiliar? And then we need to look at the whole day. Look at the pattern. Look at the rhythm of their day. How is the day being filled? Is it overwhelming? Is it too much at a time? Do we need to take breaks? And once we put those pieces of the puzzle together, we can be much more effective at coming up with something that makes a difference. I try to help people by helping them break things down into simple groupings. So when it comes to behaviors, what I want you to do is think hard. Could there be unmet needs? And think 5 physical, 5 emotional. You're always going to typically see emotional over top. They may be covering up the physical, but they may be just present. So here are your 5 emotions to be thinking about. If you see this or hear this, keep in mind they're trying to express something. The first one, the one you may see first, anger. No, no. Well, I'm telling you that I don't like something. But typically there's always something underneath there. The next one, why are you doing this? Why are you doing this? I may be really sad. Now it may be hidden or it may come out. Please, please, I want to go home. Oh, oh, oh. Those are the only words I have, but I'm trying to send a message. This one, oh, not pretty. I'm lonely. Come here, come here, come here, come here, come here. That repetitive calling out may be an attempt to get someone to come. I don't know what I need. I don't respond well when you try to ask me questions because it's not the questions I need, it's a person in touch and somebody being there. Now, this next one, this one needs to be noted. I'm scared. I'm so scared. Please, 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 please. Something you're doing or something around me may be causing me to be frightened, or my own mind, my own situation. Something's happening. But be aware of fear. It's driving me. It's making me do things. And then finally, maybe the real problem, I'm bored. I've been here too much. There's nothing going on. I can't pick up on stuff. I'm bored. So I'm doing things that people don't like because I don't know what else to do. Might be because I don't know what else to do and I'm entertaining myself. Self-stimulation. Let's real quickly go over your 5 physical, because if you have these two tool sets, it can help you better help families and help yourself figure things out. Here's your 5 over here. Keep it simple. Number 1, hungry or thirsty. Could they be hungry or thirsty? I want to go home might signal I'm hungry or thirsty. Or the battle may be you're trying to get me to eat or drink and I'm not feeling that at all. The second one, high energy. I've got a lot of energy and I don't know what to do with it because I always have been a busy person. And now because of the disease I'm immobilized, or maybe because of the medication I just got. I'm feeling a lot of energy but I don't know how to use it. This is where rhythm can really help out. Music can make a big difference. It guides and directs. But at the same time, instead I might be exhausted. I don't know I'm exhausted. It's like having a kid who's 3 years old skip their 1 o'clock nap at 6 p.m. Whoa. You've got to figure it out. And it's hard. Now the next one, ugly again, elimination issues. I've got to pee or poop, or I already did. Maybe it's discomfort and I don't understand what needs to happen. Maybe I've got an issue going on where it's building up and I don't pick up on the internal cues. I can't. And so I'm getting real anxious, real nervous, but what's really happening is I have to go. Then we have this one. I'm uncomfortable. Something doesn't feel quite right. My clothes are tight. I don't like the feel of the chair, the temperature, the people. It's too close. It's too crowded. This one's the most difficult to figure out because it's more individualized and we want to look at the person and see what happens if we make some changes sometimes to see if that brings the temperature down a little bit. In other words, makes them feel less distressed. And finally, the one that gets missed way too often. Ow! I'm in pain. So we want to check these things out because without the words, without the curiosity, we frequently make mistakes and try to cover the symptom and not manage it. It's our job to figure these things out. Be a good detective. Get curious. It makes a difference.